thank you so much to the conference organizers and especially to Kim Feeney, my beloved neighbor and friend. It's a delight to be here today, and I am, let me just see if I can just, oh, here I am. It's working. Okay, good. I want to start out with two stories that share why this topic is so important to me. The first story is about a woman going to see a gynecologist, and she is establishing care with this gynecologist. In the course of establishing care, the gynecologist begins to ask her questions, and the gynecologist asks, "Are you sexually active?" And she says, "Yes, I am." And the gynecologist says, "Any chance you could be pregnant?" And she says, "Nope." And the gynecologist looks at her, and to her surprise, the patient's surprise, the gynecologist asks again, "Are you sexually active?" And she says, "Didn't we just go through this?" She's thinking, "Yes, I am." "Any chance you could be pregnant?" "No." To the patient's surprise, the gynecologist starts a third round. Now the patient is starting to get a little ticked off. By the way, it was me. And she starts to go, "You're sexually active." And I said, "Look, I stay away from the leading cause of pregnancy, the erect penis, okay?" So now she's finally gotten it. And I was telling that story to a colleague who said, "The same thing happened to me. 3 rounds, same thing, different gynecologist, different state." So there was clearly some room for some education with those providers. And I am not getting the sense that UVM needs the same level of education, but I am here just to fill in the gaps in case there's any questions. Second story. As Kim mentioned, I started a private practice, and my policy is to do an introductory phone consultation. And so I was doing one last year, and at the end of about 20 minutes of this phone consultation, things had been going very well, and I felt like this would be somebody who I could help, and that this would be a good treatment fit. And the individual said, "There's only one more thing, and I hope it's not a problem." And I said, "Okay." And she said, there was silence, "I'm a lesbian in a long-term committed relationship." And my heart broke that she thought that that was going to be a problem, because it had been a problem for her in the past. And so, because this is what's motivating me to be here today. Let's see. Oh, so in the course, I need to make this a little bigger so I can see it better. I don't know. Let's see if I can do that. All right, I'm going to cope. So I found this quote from a really great article on folks who are sexual and gender minorities seeking cancer. And this is a quote from a person in the article. "I didn't feel seen. I kept trying to connect with name of doctor in a way that would validate me, but I never got recognized as somebody. It wasn't worth fighting to try to impress my point. I walked out of there feeling like I did everything but stand on my head to get acknowledged. It made me so angry." And this is, I think, following on the theme from what Kristen said about the importance of being seen. Objectives: raise awareness, foster understanding, encourage action to promote inclusivity, and better health outcomes. So we know that young sexual and gender minority individuals are at greater risk for adverse mental, behavioral, and physical outcomes. We know a lot about adverse childhood experiences from the studies of Vincent Felitti in California. We know that young sexual and gender minorities are going to be more subject to bullying. And the original title of my talk was different. It was The Exposome Marinade, a recipe for reprogramming human biology. And as I was getting in deeper and deeper, I realized that the talk I was going to try to give was about how the individual can manage what they're exposed to. And then I realized the onus, the burden of responsibility is not on the patient. It is on the institutions. It is on the providers to be educated, to help change what they're being exposed to. So it's not just youth. There's a study that was reported in Harvard that even dementia is more prevalent in sexual and gender minorities, which makes sense. As I was researching the first talk about the what you're exposed to, or the exposome, that's the social climate. That is, what you eat, the thoughts that run through your head. And as these things interact with you, we know from epigenetics there's going to be the possibility that a carbon atom attached to 3 hydrogen atoms is going to dock on your genes, and it's going to upregulate or downregulate things that make a difference in what proteins are expressed in your body, which could mean that you are making more proteins that cause inflammation. Or it could mean that you have things going on that affect your microbiome. And now we know that the microbiome also affects what's going on with your emotions and your processes in your brain. So everything's connected, and the sexual and gender minorities are at greater risk based on some of the exposures. Okay, forward. So we are at the cancer conference, and I am really impressed by what an impact not being seen, not being recognized can have on sexual and gender minorities when they are coming in for cancer care. And it's not a small number of people. It's about 1 million sexual and gender minority individuals have had cancer in the United States. And this is, I'm going to reinforce, this is a very diverse population with diverse needs, but I think the thing that runs true across the board is they need to be seen, they need to be recognized. And there are, I'm not an oncologist, so just, what impressed me that they had different rates of different kinds of cancers, especially when you also consider folks who are having gender reassignment. There's hormones involved and different risk factors. So this sort of reminds me of that experience with the gynecologist. She just wasn't hearing me, and part of that was because she wasn't informed. So now when somebody comes in with prior stigmatizing experiences, they haven't been recognized by their physician, or like the individual who was asking me if it would be a problem that she was a lesbian in a long-term committed relationship when she's coming in to seek psychiatric care, that tells me that there's a level of mistrust that she is going to be in an emotionally safe place. So this is a factor in cancer encounters. So the minority stress model is in my mind, is sort of a corollary to what a lot of us know about adverse childhood experiences. It sort of continues in that vein. It's basically saying that there are hostile stressors, unique and hostile stressors, that are related to their identity, and that these stressors have an effect, a negative effect on the health. The person who is credited with this minority stress model theory is Ilan Meyer, and he is out of Colombia, and he had been following cohorts of sexual and gender minorities and studying the stress that was associated with their identity and healthcare utilization. And there have been some findings that people are avoiding getting treatment that we'll go into later based on their negative experiences with healthcare. So minority stress model stressors, rejection, concealment. There was a 1996 study out of UCLA that showed that gay men who were in the closet did not do as well and health-wise when they were being treated for AIDS than gay men who were not closeted, who had more social acceptance and more social supports, and also their own sense of feeling safe enough to come out about who they were. So a sense of rejection can be external, or it could be an internalized sense of rejection. Discrimination, homelessness, we know that there are greater socioeconomic impacts of being related to being a sexual or gender minority. And this internalized stigma is something in psychiatry and psychology that's referred to as the negative introject. It's when you basically incorporate the abuse that has been launched against you, and it sort of lives on in an internal assault. So that internalized stigma, along with the external stigma, together, it's a very potent mix that's not health promoting, and of course poverty, significant barrier. So minority stress model harms are that after a while, if you've internalized this negative introject and you have this negative anti-sexual gender minority attitude and comments marinade that you've sort of adopted as your own self-talk, you'll start to accept discriminatory actions and endure microaggressions and come to almost anticipate negative experiences like this. So the specific gaps in care that were recognized in the paper I read were about people coming in for cancer care feeling as though there was that there was a lack of discussion around their sexual orientation or their gender identity. It's very important to individuals who are coming into care to have the correct pronouns used or the correct names used. And when in doubt, the best thing is to ask. It's really great to have forms that have spaces for the preferred pronouns. Front desk staff inviting someone to come back, if they're unsure, would be better using a gender-neutral term or simply asking. Insufficient sexual and gender minority patient supports were difficult. Those social supports are critical, and there may need to be some adjustments made. So we know that the minority stress can compound cancer-related stress, and if there's any increased feeling of stigmatization in healthcare settings, that can be really devastating for individuals. The minority stress can be, we look at the intersection of poverty, living in a rural area, being a racial or ethnic minority will create 3 times higher rates of behavioral health and substance use disorders. So all of this combined with a diagnosis of cancer can exacerbate cancer health disparities. So that stress of cancer, in addition to the minority stress model for some individuals, is going to mean that there is a significantly heightened need for recognition of their sexual and gender minority and caregiver preferences. I loved in the first talk that I saw today after lunch, in Kristen's talk, the fact that she's saying, I need to be seen as the support. So it's so important for the families that the sexual and gender minority patient is presenting with be recognized. There was a time where if something happened to me or my partner, I was worried that I might not be able to go to the hospital to be there because there were rules about that. So thankfully, things have changed quite a bit. So I'm going to launch into a little bit of just some gender and gender minority 101. So this is the 2018 Pride flag. This was on the eve of the 50th anniversary of the Stonewall riots. And basically, there was a mafia-owned bar in 1969 in Greenwich Village, and there were some at the time, they were calling themselves drag queens, and they were getting really sick of police raids. And there was a police raid on June 28th, 1969. Police went in, raided the place, and the drag queens fought back. And what happened was this spilled out into the street, and there were people from other lesbian and gay bars that emptied into the street, and also just passerbys in the street started to fight back with the police. This flag is an update on the rainbow flag that was created in the 1970s in San Francisco. And the update puts the is in tribute to the people of color, the BIPOC, Black, Indigenous people of color, with the black and the brown stripes, and then also the trans individuals who were critical in becoming the pillars of the gay liberation movement from that night. So there were two trans women. Marsha Johnson was an African American, and Sylvia Rivera, and they began the gay liberation movement. So that's a good place to start. This is a brand new flag that I discovered while researching this presentation, and that circle has been added to acknowledge the, individuals who are in between what would be normative assigned at birth male versus female designations. So I'm going to jump into a primer. You know, some of these are pretty evident. L, lesbian, G, gay, B, bisexual. Transgender is different than transsexual. I'll touch on that later. Q is questioning. I is intersex, which is what the circle denoted. A is asexual. And 2S is two-spirit, which is identity claimed by some indigenous individuals. I thought this was really easy. Sexual orientation, who you go to bed with. Gender orientation, who you go to bed as. But I will expand upon that. So sexual orientation, this is sort of old school. A person's erotic response, tendency, or sexual attraction. Homosexual toward their own sex, heterosexual toward the other sex, bisexual toward both sexes. But what happens if you were assigned male at birth, You have had surgery, you are now female, and you are attracted to women. Well, where does that put you? So now there's some updates, which I also learned in preparation for this talk. Androphilic, it keeps it simple, attracted to men. Gynophilic, attracted to women. Sexual identity, as part of my research, there was a great talk on the American Psychiatric Association website, ethical issues in treating the LGBTQ patients. And the sexual identity is a developmental process. It's about a person's conception of self. So not everybody who has a homoerotic desire or participates in homosexual activity develops a lesbian, gay, bisexual, or non-binary identity. So sexual identity is not the same as sexual orientation. Sexual identity is how you think about yourself. So gender versus biological sex, the gender identity is, about belonging to either a male or female gender category or some other category. Gender expression is how a person expresses gender in public. Identities are subjective, do not be afraid to ask. And biological sex in normative development is, as you would expect, determined by genes and hormones. So how many people in this room know what cisgender is? Okay. Quite a few, but not everyone. So back to organic chemistry, if you've ever taken it, and if you haven't, it doesn't matter, it's simple. So the green balls, these two molecules have the same components, but they're arranged differently. And the green balls, we'll call them methyl groups. If they are on the same side, what it means is that that's cis. So it's a concept that if you are cisgendered, the gender you identify with matches the sex you were assigned at birth. If you are trans, that is not a matchup. Okay. If you get confused, you can always refer to the Gender Unicorn. This is a national resource that's available that can just help people to understand the layers of complexity here. Okay, we need to talk about relationships with individuals who are coming in because it's, the normative one man with one woman doesn't apply to everybody who's coming in. Relationships may not, the primary supportive relationships may be from families of choice. As I had mentioned earlier, families of origin may have been rejecting, they may be non-supportive. There may be polyamory, there may be non-monogamy. I've been hearing a term, ethical non-monogamy. There are stable three-person relationships now, thruples. So these are considerations when individuals are coming in telling you who the important people in their lives are. Here are some other terms. We have to remember identities are subjective, and pansexual may mean one thing to one person who identifies as pansexual and something else to another person who identifies that way. Gender fluid, gender nonconforming, non-binary, genderqueer, bigender. Gynandromorphophilic, this is heterosexual cisgendered men or straight men attracted to trans women. Asexual, this is a diverse community. It's super critical to understand that we have moved, thank God, beyond the age of conversion therapy. We have moved beyond the age of pathologizing individuals who do not conform to a cisgendered heterosexual model. gender incongruence is not a psychiatric diagnosis. This is a medical diagnosis now, and it is a marked and persistent incongruence between a person's experienced gender and birth-assigned gender. Okay, transsexual is different than transgender. Transgender is about identity. Transsexual is a medical term, and it involves either hormones, surgical treatment, or a combination of those. You're going to remember if somebody is sexually assigned male at birth, transitions to a female, where a person lands, who they perceive themselves, how they perceive their own gender is how they are to be addressed. So it is dead naming to use an old name that somebody doesn't want anymore, that is perceived as hostile, and it can be tricky. I had an individual reach out to me, and the name appeared to be a name that would be associated with a male gender. And so I was bringing them on. I had asked about pronouns, but then I got another email, and I was confused because it was from a woman, but it was also picking up the conversation we'd already had. And I said, I'm sorry, I don't have a release to speak to you about the care of this individual. And the answer I got was, oh no, it's still me. This is the name I use for people in my inner circle. So you have to be on your toes sometimes. And the name was from a female gender. The intersection of being trans, being a person of color in the United States is associated with heightened risks for violence. If you add that, add any kind of poverty or homelessness to that, the risk amps up. I like this picture because I like the motorcycle helmet. I like motorcycles, so I picked that for RuPaul, who would probably be somewhat isolated because he is an affluent individual. She is an affluent individual. My big mess up there. But when you mess up, which I have done at times, it's really important to acknowledge it and to say, I'm so sorry, I just did that, and to check in with the individual who's in the room with you. So, another key point to this slide is that there's a lot of legislation right now that is attempting to limit transgender people's access to healthcare, bathrooms, sports, recreation, and what that does is create an idea that it's okay to marginalize this section of the population, and that promotes violence. So there's too many words on this slide, but I wanted to put it down so people can understand that it's multifactorial why there's so much violence against transgender and non-binary people. It's about stigma. It's about the socioeconomic impacts of being a sexual and gender minority, and it's about increased risk factors. If somebody is homeless, they've been rejected, one of the things that came to my attention was it can be very difficult for somebody who is trans to get an ID to go get a job if they're changing their identity. And there can be issues with that in different places. And so if somebody's having difficulty because of rejection, because of stigma, because of poverty, because there are all these obstacles in their way, they're more likely to resort to being a survival sex worker. So there's all kinds of, impacts from being denied access. This was one of the most shocking aspects of preparing for this presentation. As a physician, it's so important, in my mind, to create emotional safety for anyone coming in to seek care. And it was really upsetting to read about reports that folks going in to get care may actually end up being physically assaulted. That was just, shocking to me. So like the individual who had reached out to me and was not sure if I was going to be a safe place because they had had religious statements made to them. So this was a survey, and more than 30% of people had to teach their doctor about trans or non-binary people to get care. 23% reported providers made religious statements about their gender identity. 20% intentionally misgendered, wrong name used. 21% reported providers visibly uncomfortable. 17% reported harsh or abusive language. 11% reported unwanted physical contact. 9% reported physically rough or abusive behavior. 51% of all the folks polled had at least one of these negative experiences in the last year. Not okay. So taking action, it's important to expand and protect healthcare coverage, increase provider expertise and cultural competency. I'm so glad to be invited here to help do that. Provide transgender and non-binary specific social services. Every major medical association supports gender-affirming care. It's not up for debate in the medical community. It's the right thing to do according to the American Medical Association, the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatrists, the American Academy of Pediatrics, and the World Professional Association for Transgender Health. So, how do you create a safe space and culture? You want to, as I've said before, greet patients with their preferred name or pronoun, reaffirm confidentiality, make sure that there's a place that they feel welcome to use the restroom, provide non-discriminatory policies, and post friendly symbols in the environment, in the waiting room or in your office, and make sure that your staff is on board. This is what I do. This is my front of my office, a rainbow mat. You are seen, you matter, you are valued, you are beautiful, you are honored. You belong here is a message in my waiting room and in my office. And I figure just be yourself covers everything on my front door. I would love it if people just took a minute to ask the person next to them, what's your preferred name? Where does your preferred name come from? And what are your preferred pronouns? Just take a minute if you have somebody next to you. Wow, that's a lot. That's a lot. There's a lot behind that. It sort of woke the room up, too. I recognize you guys have been at it for a while today. And it wasn't that hard, but the really cool thing from here was how it brought the room to life, because there was sharing and there was curiosity and there was acceptance. And it started a great dialogue. Okay, so healthcare providers need to be informed. I'm starting to wrap it up. Not all patients are heterosexual. LGBTQ plus patients might have kids. Gay men and lesbians may sometimes have sex with the opposite sex. Early same-sex erotic feelings may not be a phase. Gender identity confusion does not need to be resolved toward a male or female identity. Domestic violence can occur within LGBTQ plus relationships. Relationships may not have established sex roles. The World Professional Association for Transgender Health is a good resource to know about. They provide standards of care, ethical guidelines for psychological, medical, and surgical management. Unfortunately, not all institutions or insurance companies are paying attention to these recommendations. And my summary, LGBTQ+ community is super diverse. They have increased mental and physical health burdens in this community, and the minority stress model is an explanation for that. Sexual and gender minority patients have unique needs when they have cancer. Healthcare providers must be informed to provide effective care. It's up to institutions to remain updated on resources and guidelines, and it's really important to provide emotional safety signals to your patients when they are coming in for care. Final thought. This is from the Human Rights Campaign site. Resiliency is that small ember kept warm by love, encouraged by hope, lifted in faith, that reminds us that we too have a right to be here. There are so many who look at us and say that because we are who we are not enough. But I have the prayers of my parents, the courage of my child, the substance of my ancestors reminding me that yes, we are enough and we can and must keep going. And that was from Ia Porter, a member of the Human Rights Campaign Foundation's Parents for Transgender Equality. And with that, I'm, I think 40 seconds over, not too bad. And I'm opening it up to questions, if there are any. Oh.